ठीक है, शुरू करते हैं. So now on behalf of Jayaprakash Narayan Apex Trauma Center, Division of Orthopedic Trauma and Department of Orthopedics, I welcome you to this very interesting, CCR on orthopedic trauma. Normally, if we see crushed limb is a very challenging task. It's very difficult to reconstruct with loss of soft tissues, vascular injuries, nerve injuries, and bone loss and high risk of infection. So, I mean, if such patients, they require a lot of dedication and passion and really perseverance on the part of all the physicians treating, surgeons, plastic surgeons, vascular surgeons, as well as the infection team to get a good outcome. If you go to periphery, I think the first response or the first reaction is just to amputate the limb. But yeah, I mean, it can be saved, and this is a very interesting case. May I now invite Dr. Arvind, Assistant Professor in Orthopedics Trauma, to present this CCR.
Thank you so much, sir. So, if we talk about orthopedic trauma, the thing that comes in our mind is that there must be a fracture and the orthopedic surgeon probably need to fix it. But often there are deep intricacies involved, and the management is not as simple as the preoperative and postoperative radiograph. So, our title of today's presentation is Engineering Biology from Salvage to a Functional Limb, because that is the primary aim we want for every patient. So this was a 16-year-old female patient who had sustained a road traffic accident, and she had been referred to us with this kind of presentation. And you can see whole of the lower limb is degloved and some part of the tibia is also exposed. So if we just imagine what kind of 3D anatomy of bone is there, so there is an external fixator which is lying outside the tibia, and there's probably some hardware lying here. And if we zoom in, we'll see that whole of the tibia is devoid of any vascularity, it is exposed. So what's next? So this is a dead bone. This is completely devoid of any circulation. So the issues that we are facing at this current stage is the dead bone, and obviously there is no skin cover. The fracture stability is compromised because only a temporary measure of fixation has been applied right now, which is an external fixator. This is external fixator frame. And the foot position is an issue because you can't keep a foot like this because it is prone to contracture development. And infection control is big issue because this dead exposed bone as well as whole of this exposed deep tissue is prone to infection. So for the management of dead bone, the universally accepted guideline is that we have to remove it. There's no other option because otherwise it will act like a nidus for microorganisms. So if we remove this bone, what options do we have? Can we apply a bone graft? The issue will be that there will be need for extensive bone graft and there will be graft site morbidity, and such a bone graft will be devoid of any viability and strength. So there is another procedure which has been established in literature, which is known as bone transport. In bone transport, what we do, we cut the proximal end of the intact bone and gradually around 1 millimeter per day, we transport that segment distally to the site of void. And what happens in the proximal part, there is new bone formation, which is known as dissection osteogenesis, while on the site where this segment is transported, when comes in contact, forms new bone, which is known as transformational osteogenesis. So by that, we are having bone on both the sides here as well as here. But the issue with such injured limbs is that whether such a procedure is feasible in these cases or not. So what happens? In such cases, often with time, the scar tissue shrinks. And when we transport the bone, ultimately the bone is going to be extruded from this part. So we need an alternative procedure in which the soft tissue envelope of the contracted part can be preserved. So for that, again, in literature, there is an evidence-based procedure called induced membrane technique, which was devised by Mescule and his colleagues. So in that, what they do, in the void that is covered with soft tissue, they place an antibiotic or plain cement spacer. Plain cement spacer, that means polymethyl methaacrylate cement spacer. And with time, in around 4 to 8 weeks, a membrane is formed around this cement spacer. This membrane is highly osteogenic and vascular. And when this cement is removed and placed with cancellous graft, replaced with cancellous graft, there's formation of new bone and that gets consolidated over time. So in stage 1, we place the cement block. In stage 2, we remove the cement block and place bone graft in this space. So the same thing was planned for this patient as well. And you can see this is an illustration of showing this stage 1 in which the void has been replaced with a cement spacer. No, not same patient, just an illustration. So here now we have addressed the issue of dead bone. That means we are going to remove it. Skin cover will be applied by skin grafting and also by the cross-legged flap, which Dr. Suashish, our plastic surgery faculty, will tell in detail. And foot position is still an issue, but we thought that after union at the tibia, we'll address the foot position also. And infection control to some extent was achieved by placement of antibiotic cement spacer. And stability was again temporarily by the external fixator. So I'll invite Dr. Suashish to kindly tell basics about the cross-legged flap. Over to you, Dr. Suashish.
Thank you. So before going, let's understand the function of lower limb is weight bearing and locomotion. So this is the flap we are talking about. So let's begin with the story. Without the stability of bones, we cannot stand, but the soft tissue coverage is needed to protect the bone. If the bone is exposed, there will be osteomyelitis and it will go. So for this kind of coverage, you cannot put a skin graft over the bone because the skin graft will need something vascular to stick on. So here we need a flap. A flap is something that has its own blood supply. But we have another problem. The problem is there is no vascularity. The tibial vessels are gone. So when we plastic surgeon, we approach a wound cover, we use the reconstructive ladder that is from simple to complex. So we have different armamentarium of flap, local flap, regional flap, free flap, and if all fails, then we go to this flap. So that is a cross-leg flap. So what we did, we take a tissue from the opposite side of leg and put it over the here on the wound. So here the problems are all the major tibial vessels are gone. The limb only surviving with the collateral circulation, and so we don't have any free tissue transfer. We don't have. So we take a flap from the opposite leg. So this is what we have done. So first, in the first picture, this is the flap design. We have taken the flap. We have raised the flap. Once we raised, this is the donor leg. We put it over the recipient leg. And after 3 weeks, we divided. So in between, what happened? In between, the flap has integrated with the donor side. The circulation comes from the recipient leg. And once we are satisfied, the circulation is continuous, then we divide it. So this is called orthoplastic approach. So here two teams, orthopedics and plastic surgery, they work in hand. And so orthopedics, they will do skeletal stabilization. Here also destruction osteogenesis is done. And we have to give the soft tissue coverage, that is a durable soft tissue coverage. So in this way, you can have a durable limb coverage. So with our collaboration, we have made possible this kind of limb can be salvaged with a cross-leg flap. And here we have to understand if the patient is comfortable in this position, then you have a good flap outcome. And I'll now invite Dr. Nihar to proceed further.
Good afternoon, everyone. Now the remaining issues are the foot positions and the union. Okay. Now, after maturation of the graft, at 5 months post-injury, we are planning for the induced membrane technique stage 2. In this procedure, you can see this is the induced membrane and this is the spacer from the stage 1 procedures. Now, after the removal of the spacer, we have filled the void with bone graft from the same patient, and the fixation of this the options will be plates. But as the patient is having less space around the tibia, the option of plate will not be possible. And the other option is nail that is put inside the tibia, and there will be no problem of space. Now the other issue will be osteoporosis and fracture union. But after the procedure, the patient has developed exposure of the screws, and on imaging we can see back out of the screw. So the screws are removed, and we have managed the patient on slab. But after 3 months of the plaster, the patient still have the issue of foot position, and there is no union, as you can see this side. So other issue being dealt with, the another issue is the psychological and social impact. As the procedure is prolonged duration of 1.5 years, and another issue is that patient is approaching 18 years, and in our local area at 18 years there is marriageable age. But due to the deformed feet and unable to bear the weight, that is a social stigma in our area. So the definite fixation, the options are: one is external fixation, but that is not possible as the patient already has nail inside the tibia. There is limited space, and the screw pin diameters are more, which may more damage the already osteoporotic bone. And the other option of plate, that is also not possible because of the limited space around the tibia. So for this, we have searched the literature where one procedure is described by B.B. Joshi, that is Joshi external stabilization system. That is a simple method that is based on K-wires. It is a simple and versatile design. This is lightweight. This acts as a augmented fixation. That means that it can be added along with the tibia nail that is already inside the bone. And it is based on the variety of K-wires, sizes and pins, and it is modular implant. That means the implant can be modified on later stage as per the need. So here you consider that the just fixator with loose nail that will give more stability, and that will help for union. So the other remaining foot deformity that is still there, and that will be dealt by Dr. Tejas.
Hello. Good afternoon, everyone. So why this foot is getting deformed? So we have two reasons for this. The first one is gravity, and the second one is the pull of the muscles of the posterior compartment of the leg, which is unopposed by the shrinked and atrophied muscles of the anterior compartment of the leg. So to correct this foot deformity, we went through the literature, and there was a procedure devised by Lambrinudi. This procedure was classically used in foot drop patient to correct the foot deformity. In this procedure, the deformed part of this talus bone, it is removed and it is fixed in a neutral and plantigrade position, and some amount of ankle movement is also preserved. So we tried to employ this procedure to correct our foot deformity. So this was the theory part, but in reality, it was not what we had apprehended in this procedure. As we already know that this limb is surviving on collateral circulation. So if we acutely correct this foot deformity, the vessels will be stretched and kinked. So we will need to closely monitor the foot vascularity after acutely correcting the deformity. So at 18 months post-injury, we did the foot deformity correction surgery, in which we utilized the area where the skin was most adherent to the bone. We went bone deep to preserve vascularity of the skin, and we did not use any tourniquet. So this is how we created a plantigrade, normal-looking foot and ankle. In this surgery, we used 2 sets of rods for correcting the deformity. We can see there is an anterior row of rod. It is used to maintain the foot in the neutral plantigrade position, and there is a posterior row of rod which is used to stabilize the tibia fracture non-union. So we were able to address most of these issues of the patients. The osteoporosis issue was able to be solved because now the patient is able to bear weight on her limb, sorry. And when we bear weight on the limb, the bone gets consolidated, and the osteoporosis gets countered. The surgery also was a great psychological boost for the patient who was looking at a non-deformed foot. The issue of fracture union was also resolved. For this, I would like to review a paper by S.M. Perrin in which he demonstrated that different types of tissues are formed when there is different levels of strain across the fracture site. Strain typically means the amount of motion in between the fracture site. So if the strain is 2 to 10%, a woven bone will be formed. If the strain is less than 2%, a lamellar bone would be formed. In our situation, a low strain environment was necessary for bone consolidation. This low strain environment was created by already supplementing the nail which is inside. This is inside. It was supplemented by the posterior rod of the jest fixator, and thereby we were able to create a strain less than 2%. The strain of 2 to 10% was not feasible because the bony ends were atrophic and non-vascular, which would not be able to form callus. So did the surgery go uneventful? No. Around 3 to 4 hours after surgery, we found that the foot of the patient started to become cyanosed and dusky. We were vigilant enough to notice this. And what we did was we relaxed this anterior rod. We relaxed the anterior rod, the rod which was able to maintain the foot in the neutral position. And immediately 1 hour after relaxing the anterior dorsiflexing rod, we were able to see that the cyanosis disappeared. But return of circulation does not mean that there is an adequate tissue perfusion. Since this limb is already vascularly compromised, and we already did a major surgical procedure to correct the foot deformity, we anticipated that the foot will develop swelling and blisters, and therefore we did not do any circumferential dressing to prevent any more constriction formation. We simply did dressing with normal saline, and we did pin side dressing. In addition to that, what we did was we supplemented the patient with pentoxifylline, which has some evidence in the literature. It is used in chronic venous ulcers and peripheral vascular disease to increase the vascularity of the limb. So as we apprehended, the soft tissue condition improved over the next 3 weeks. So this was the X-ray of the patient 20 months post-injury. We removed the jest fixator when we saw the radiological signs of union at the fracture site. This is the previous X-ray. This is the X-ray at 20 months post-injury. We can see that there's an anterior bridging bone that is formed, and we can see it in the CT also. This is the anterior bridging bone that is formed. Regarding the foot position, earlier the long axis of the leg was almost parallel to the long axis of the foot. But now, after the surgery, we can see that the talus and calcaneum, they both are acting as a single unit. And the axis of the foot is almost perpendicular to the axis of the leg. So that's how we were able to correct the foot deformity. So now the final follow-up, at the final follow-up, 23 months, the patient came to us with a full plantigrade foot Without using any crutches and walker, she was able to walk, and she was more than happy and contented because of these results. She was able to move without assistance. She was employed, and last but not the least thing, that she got married and she came with her husband for her final OPD. So we can see that these small nuances that we do during the surgeries, it can have a very large impact on the outcome and the psychosocial impact of the patient. So limb salvage is a journey. It is not a single operation. Careful staging, respecting basic principles, and vigilant post-operative care can restore both bone and function. Thank you. For closing remarks, I would like to call Dr. Arvind sir, please.
He's already said all this. That is the journey. So we have to be vigilant. We have to ask the patient for the patients also. That means every single step we are performing a surgery, we have to wait and watch. And if we have patients, I think, and all the plans that have been done, they are evidence-based. So ultimately, we are going to get results also. So that was the thing. Thank you.
Any questions from the audience?
Yes, tibial shaft non-union was there. So that was addressed with the JES frame. So simultaneously, both the foot deformity and non-union, they were both addressed simultaneously. First of all, we had planned for tibia union addressal by the nail, but when it was not uniting and the foot was already getting further deformed, we planned for a single procedure in which we address the tibia with the proper unit of the JES, and other unit of the JES was used for correction of the deformity of foot. It took around 6 months after JES. So overall, it was almost 2 years, but after JES application, it was 6 months. No, after mescule, it took 1.5 years. After mescule. Yeah. After mescule, it went into non-union. The tibial screws were extruding, and there was gross mobility at the fracture site. After mescule, 6 months. So then the JES was supplemented. Primary trauma was a crush injury, road traffic accident, in which there was degloving of whole of the lower limb. Right. And there was a tibia fracture also associated with it.
Yes, that is the interesting thing. So the name itself suggests reverse sural flap. Usually the blood supply comes from the center to periphery, that is from heart to periphery. So if you see in limb, there are some vascular territory that is called angiojomes. So major vessels, from major vessel there is a perforator that comes from deep to superficial. From just below fascia, the perforator perpendicularly enter, sometimes obliquely enter. Each perforator supply a certain area that is called an angiojome. But like to think of two map of two countries, but between two countries there are some illegal pathways, so their infiltration occur. It's like that. So now what happens? We can manipulate that vessels. Those vessels are called choke vessels. Now that is one concept. Second concept is there is a nerve on the posterior side of leg that is called sural nerve. For that nerve, for every nerve there is bhasa nervosome. So this flap is basically based on that bhasa nervosome. So this is a neurocutaneous flap. So along the pathway of that nerve, there are some perforators supplied by peroneal artery. The peroneal artery supplies the perforator that supplies the nerve, and we have taken advantage of that nerve as well as the angiojome concept. That's why. So you have to understand little anatomy basically. So, that's why, sir. I am praising him actually, sir. I mean, sir, the basic of all MBBS and every medical is I am giving credit to him. So for anatomy, so we have to go arterial perforator, not venous perforator. No, sir. It's a exactly, sir. Cormac Lamberti, the best book ever. Arterial perforator. Sir. Proximally based flap, here it is difficult. So unless you have the pro, sir, before the angiosome concept, whenever you are taking the flap, we used to take flap 1:1 ratio, length 1 centimeter, breadth 1 centimeter. If you take a longer flap, the tissue perfusion has to be there. If you're taking a longer flap, that flap has to be tissue perfusion has to be there. So if you take a random pattern flap, the tissue perfusion only occur by dermal arcades. If you are taking a longer flap, there has to be axial vessel. Let's say I am taking a radial artery forearm flap. So radial artery should long along the flap. So here, like this is a axial flap, we can say, because the flap is a neurocutaneous flap. Unless there is a vessel that is running in the flap, we cannot take a longer flap. So once Pontin described the fasciocutaneous flap, you have to incorporate the fascia, then only the flap blood supply will be robust. Only dermal supply will not help. Yeah, but the perforator from the peroneal artery is supplying, that's why. Tony sir.